Good morning. This is Babak, Larian, coming to you live from home for another parathyroid Q&A. Had a little bit of technical difficulty, and you may hear some kids in the background, maybe even rushing into the room, and so on. In any case, but I'm happy to be able to do this. And in this wild time of COVID-19, at least we have this platform to communicate with each other and still have access, and hopefully I can be able to answer some questions for you guys and help you along this challenging path. I have to say, I found most of you that come onto this Q&A to probably be more informed than most of the physicians out there about hyperparathyroidism, and the questions you ask and the follow-through that you have and the follow-up that you do really confirms this fact for me. And that's really something to be said about this particular disease, because the amount of information out there available is a lot. The level of understanding of the physicians is not quite so much, because it's not a commonly diagnosed disease, even though it's a very common disease, and it's not a commonly treated disease by the frontline doctors who address these symptoms. So when you have these symptoms and you go to your primary physician, they don't get to treat this. Even if they get to diagnose you, they don't get to treat it, and they don't get to understand this disease so well. In any case, so you guys actually become your own agents. You guys become the people who make an impact, a difference on your own life, and make a difference on requesting treatment, on making sure things are done for you. And I want to empower you to be able to do that. And that's the most important thing I can do for you, to let you know that you're on the right path, that you're thinking well and correctly, and obviously you know your body better than anyone else, and so you know that there's something going on that's wrong, and so advocating for yourself is the most important thing that you can get out of this thing, besides some information. In any case, let me start. We don't have as many questions this time, so I'm going to start by just going through hyperparathyroidism briefly. And unfortunately, Facebook doesn't let me change the orientation of the phone, so the camera is a little funky, but here we go. So, in a normal parathyroid gland environment, when the calcium level is low in your bloodstream, your 4 parathyroid glands produce PTH. And PTH goes to your bones, the biggest storage of calcium, and tells them to release calcium into the bloodstream. Goes to your kidneys and says, reabsorb calcium from the urine, put it in the bloodstream. In the kidney, it activates vitamin D, 25-hydroxyvitamin. This is the form of vitamin D the blood tests show, the regular routine vitamin D blood test. But this enzyme, 1-alpha-hydroxylase in the kidney, transforms it to 1,25-dihydroxyvitamin D3. And when it does that in the intestines, it helps you absorb more calcium from your food. So without the vitamin D, the absorption of calcium is minimal. With the vitamin D, is actually very optimized. Vitamin K2 also helps with the process of calcium balancing and absorption and so on. In any case, all this calcium goes into the bloodstream, and as the calcium level increases, when your calcium level increases and goes too high, the glands shut down, right? So, in a normal parathyroid environment, what you're having is a relationship between calcium and PTH that's governed by this sensor on the surface of every single calcium cell, which is called the calcium sensing receptor. When enough calcium's attached to it, the cell stops producing PTH. And when there's not enough calcium's attached to it, it produces PTH. So the relationship between calcium and PTH is this curve, right? And on this curve, you have that dot. That dot is called the calcium set point. Each of us genetically have a certain calcium set point, right? We're born with that number. We're going to die with that number. So this information about your calcium should be this at this age and that at that age is not accurate. our calciums are set and genetically, and this sensor on your parathyroid cells is set for a certain number, and all your life it maintains that functionality and tries to keep your calcium. So for this person, that's 9.5. When the calcium goes from 9.5 to 9.4, there's a 30% increase in PTH. This is percentage points in PTH. By the same token, if your calcium goes from 9.5 to 9.6, there's a 30% or so decrease, maybe 25% decrease in PTH numbers, so that the calcium can go back down towards the 9.5. So the system is well geared to maintain your calcium in a tightly controlled, narrow range. And so, although when you do go to a lab and they say your range of normal is from 8.5 to 10.2, that's not where you operate most of the time. Most of the time, you're in this narrow range. So 95% of the time, you're going from 9.2 to 9.8, occasionally coming higher, occasionally going lower, with rapid responses by the parathyroid gland with increasing and decreasing PTH to respond to this. All right? So, why do we have this tight control? Why is it necessary to keep the calcium in a tight control? Because, as an example, when a nerve sends a signal to a muscle or another nerve, that connection point, these are connection points, right? We call them synapse. So a synapse looks like this. This is the nerve that's sending the signal. This is a nerve that's receiving the signal, right? When the signal comes out, it's an electric signal that comes down the fiber, right? And when the signal comes down and gets to the end of that nerve opens up calcium channels, which you see in green. Calcium rushes in. The amount of calcium that rushes in dictates how much neurotransmitter, dopamine, serotonin, whatever, gets released. So if the magnitude of the signal here is 90, and your set point for calcium was 9.0, right? And the signal that comes down here expects the amount of calcium on the outside to be 9.0, so it opens up 10 channels, 90 calcium elements come in. And the signal that goes through is a magnitude 90 because that's how much serotonin, let's say, is released, okay? But if, on the other hand, what happens is that your calcium is now 10, right? And the signal 90 comes, 10 channels open up, 100 calcium elements go in, so the magnitude of the signal that goes there is 100. So the signal is not accurate, right? That signal being inaccurate gives you inefficiency in function, brain fog, memory issues, being irritable because things are not as you expected them to be. Your emotions are affected by the chemical malfunctioning of the brain, which causes anxiety, potentially depression, right? It causes your intestines to not function properly. So some people get constipation, some people get acid reflux, right? The bladder doesn't squeeze quite so well, so you maintain more urine every time you pee out, you urinate out, a little bit of urine is still maintained in there because your bladder doesn't squeeze completely, so you keep feeling like you need to go to the bathroom more often. And a whole bunch of other inefficiencies develop in the system, giving you all these vague symptoms at the beginning. But over time, what you feel is that, my God, my body feels older, like it's not just functioning well. Like it's not optimal, which is exactly what happens. You're not optimal. So then, how does this develop, right? Well, it develops because there is a change, a mutation in this receptor or some of the mechanism involved between this communication. So that one cell that has that mutation now has a higher setting, while the normal cells have a regular setting. So the normal cells are set at 9.0. The abnormal cell is set at 11 in this picture. And as the calcium levels go up, the normal cells stop working, right? Because they come down this curve. And the abnormal cell is just working hard to get you to 11, right? And as it works harder, it duplicates and gets bigger and bigger until this turns into a tumor that's growing, right? To maintain that number 11, and the normal parathyroid cells go to a smaller sliver at the edge of it, right? So the parathyroid adenoma, by definition, is a tumor that has all uniform cells originating from this one cell here that kept duplicating and got bigger, and the normal parathyroid got smaller and smaller and sat on the edge of the parathyroid. So that's how it develops. And then you get the slew of symptoms that occur. And what are those symptoms? These symptoms: fatigue, bone pain, muscle aches, concentration issues, memory problems, irritability, sleep problems, nighttime urination, depression, urinating frequently, headaches, anxiety, thirst, increased thirst, upset stomach, constipation, abdominal pains, incontinence at times, nausea and vomiting. I mean, these are the symptoms. And another study which was done by this group, by Larian, looked at the calcium level to see if the symptoms are much higher based on calcium. And calcium less than 11.2 as compared to 11.2, the frequency of symptoms was not different, right? So it's not only a calcium number issue in terms of symptoms, it's also a PTH number. It also has to do with what your starting calcium point is and how far of a difference you have, okay? So that's the disease in a nutshell. But the disease doesn't always present as a tumor. The disease can present 85% of the time as a single tumor, an adenoma, 10% of the time as multiple tumors, 5% of the time as hyperplasia, which means every single cell in every single gland is abnormal, right? All of them are malfunctioning or overfunctioning, not one cell that turned into an abnormality that grew in time to become a tumor, right? Parathyroid cancer is, fortunately, it's exceedingly rare, and those patients have very high PTHs, right? So when a patient presents to the office with a calcium of 12 and a PTH of 600, 700, 800, that's when I start worrying about a parathyroid cancer developing, okay? So the next step in the process is obviously trying to identify which gland is abnormal, which is done through what we call localization studies. I usually start with an ultrasound because it doesn't have any radiation exposure, and a great majority of times I'm able to find it. This is an ultrasound I did in the office. This is the thyroid gland, and this is the parathyroid. Parathyroids are usually dark on ultrasound and have a white shadow. I rarely use the SESTA-MEV SPECT scan because the accuracy rate of it is dependent on the PTH level. The higher the PTH, the more accurate it is, but the higher the PTH, the larger the parathyroid, and the larger the parathyroid, the more likely I can find it on an ultrasound and a 4D CT scan. And so the accuracy of the SESTA-MEV SPECT is, for me, not accurate enough to be useful. So I rarely use it. I use it when the other two scans are negative, and I'm still trying to find something. In any case, the PET choline scan is also a newer study that's not very commonly available, but it's another tool in our armamentarium. And then there's the venous sampling, which, unfortunately, its usefulness is great when a patient hasn't had surgery, but that's not the time we end up using it because these other modalities exist. We use it usually after someone's had surgery, which now the vasculature in the neck has altered and changed, and now the accuracy goes down. So in any case, once that's discovered, then we have to decide on the surgery and proceed with surgery. And so I choose to do the surgery with PTH testing because the half-life of parathyroid hormone is 5 minutes. So when you have one parathyroid tumor that's producing a lot of PTH, right? And these are putting very little. So very little PTH here, large amounts of PTH there. So these are little, this is a massive amount, right? 180. When I take this out, the other glands are shriveled up and are smaller and not producing a lot of PTH, become to take time to start activating and get going. So when I do the surgery, I do a PTH level before I take out the tumor, and then at 10 and 15 minutes. If I get more than a 50% reduction, then I know the other 3 glands are dormant, surgery is successful, I've only come and operated in this area of your neck, and I haven't touched anything else, right? But on the other hand, if the PTH doesn't go down, I check it, the scan had only showed this, or the scan showed this and showed maybe potentially something else on here. But if the PTH doesn't come down appropriately, that's when I say, okay, I'm going to extend my surgery make it less of a minimally invasive. This is minimally invasive. If I go and look at all 4, this is not minimally invasive. This is a typical parathyroid surgery, right? So I look at this one, then I'll find a target number 2 and say, okay, on my ultrasound, I thought that this one was the second one, or a 4D CT scan, or any of the scans. And then I'll go to position 2, right? So PTH went from 180 to 142. After taking this out, I'll go here, look and see if I see an enlarged parathyroid. Enlarged parathyroids generally, instead of being flat, are rounded, right? They have a more brownish color as opposed to yellowish fatty color, right? And they have usually more robust blood vessels on the surface of them. So there are many different ways of trying to figure that out, right? So I take it out and check the PTH again. If the PTH comes down after 10 minutes to 12 and 9, then I know the remaining 2 are dormant and I'm done. I had a double adenoma, surgery's over and successful. I have only gone to these areas and not touched all the other areas in the neck. I still remained minimally invasive in my approach to a person. The reason this is important, the reason minimally invasive is important is because every area that you touch as a surgeon turns into scar, right? So when you have developed one adenoma, right, the chance of getting another adenoma in your lifetime is reported anywhere between 3 to 14%, right? Because the toxins that you're exposed to in your environment, the hormones, the preservatives, whatever else in your environment that caused the first tumor is still present. We don't know what they are to tell you to exclude them. And so there is a 3 to 14% chance of getting another one. So if you get another one here, right, 10 years later, 20 years later, if I have not touched this area and violated it, there is no scar there. I can go in there and take that out. And another thing is, when you go in and do surgery on all 4, there is a potential for you to cause scarring. And by causing scarring, you can either cause damage to the parathyroid itself, right? Or you can cause damage to the blood vessels that feed the parathyroid, right? Every parathyroid has blood vessels coming to them, right? So if you do surgery here and you unintentionally damage one of the blood vessels, right? Either one, that will cause the parathyroid to not have blood flow to it and may die and will die. So when you do surgery on all 4, you don't know how many of the remaining parathyroids have survived the surgery, right? So you try to be minimalistic in order to avoid things. Yeah, and that's the basic premise of minimally invasive surgery, to be minimalistic under the surface. In any case, at least that's my philosophy, and that's what works in my hands. Others may not agree, and that's okay. And it is basically your job to figure out what philosophy makes sense to you as you approach this as a patient who's going to see a doctor, right? So I'm not saying anybody else is right or wrong. I'm saying in my mind, this approach is what makes most sense, right? Anyways, moving on. Not to create controversy, right? So when you have one parathyroid adenoma, this is the steps of surgery. First, to make an incision, right? I'm gonna zoom in a little bit here so you can see better. So this is a cross section. If you were to do a cross section here, it would look like this: skin, fatty layer under the skin, muscles under the skin. This is the thyroid gland, breathing tube, swallowing tube, vocal cord nerve, small parathyroid and large parathyroid, right? Okay, so we make an incision. This incision usually is 2 centimeters or less. You separate the skin, which is a small area here, magnified there. You can see the muscles now. You see these from above, right? Next step, you retract. You use a retractor to push the muscle away so you can see the thyroid there, the breathing tube underneath it. Then you retract the breathing tube and the thyroid to see the nerve and the parathyroid. Nerve and the parathyroid, right? If for some reason I needed to see the other parathyroid, I would retract, change the position of the retractor, go up and find this other parathyroid up there, while being able to still see the course of the nerve, right? But I only do that if I needed to. Right, so, and then I would remove the parathyroid, close the two tiny little blood vessels here attached to it, check the PTH level, and if the PTH level goes down appropriately, my surgery is done. I suture the muscle. I put one suture in the muscle there to bring it together, and that's to prevent the skin from attaching to the thyroid or the breathing tube, right? The muscle separates it. Close the skin in 2 layers, one layer in this deeper, one under the surface, right? Skin is closed. Put a tape on, patient goes home. I usually make a sheet that shows me where was the parathyroid that I removed. Here, let me zoom out again. Where was the parathyroid that was removed, right? Where I found the nerve to the vocal cords. Sorry. Right? I draw it in all orientations, right? The nerve, recurrent laryngeal nerve, where the tumor was. If there was a nodule, I remove it. This is the thyroid nodule here. If I remove it at the same time, again, recurrence rate anywhere between 3 to 14%, just like we discussed, right? And then I put patients on a calcium replacement based on this regimen, right? Calcium, vitamin D, and I also use magnesium. Magnesium helps stabilize things a little bit. Right? If the patient has hyperplasia, which means all 4 glands, now hyperplasia manifests in many different ways. 4 gland symmetric hyperplasia, more common in patients who have dialysis. In most patients who have a non-dialysis based hyperplasia, they have asymmetric hyperplasia. Each gland is a different size, right? And sometimes you can get an adenoma on top of a hyperplasia. This is a common cause of failure of surgery, right? Because these 4 glands all have hyperplasia, and one of them develops an adenoma that really shoots it up. So even these abnormal glands get suppressed, and they may appear normal in shape and size because they're not actively working as hard as this thing is. In any case, in the past, we used to do a 4-gland parathyroidectomy where all 4 glands were removed, and then reimplant half of one gland, right? Take half of this gland, chop it up into little pieces, and put it in the muscle. Traditionally, it was in the muscle of the arm, the forearm. Some people put it in the neck. I prefer to put it in the muscle of the neck because it's the same incision and I'm right there. Some people do a 3.5 gland removal and leave half a gland in place. So, meaning instead of taking this gland out that has inside the body blood vessels attached to it, you'd go in and remove the half away from the end that has the blood vessels coming in. Fortunately, the 2 blood vessels come from the same end, which allows you to do that. So you have a gland that's intact and has blood flow. You know, when you do this procedure, when you reimplant a parathyroid into a muscle, there's a 20% chance that parathyroid may not work. So 20% failure rate. When you leave it in place, that failure rate is significantly lower. So that's good. And sometimes you do just a 3-gland removal. So let's say the last gland that you had was normal size. So let's say this is a normal size gland, and that's what the gland that you had was. You may choose to leave that in place, Because all you're doing when you're treating someone with hyperplasia is reducing the number of abnormal cells, right? If you reimplant half of this thing, you're reimplanting half of an abnormal cell. You're not curing someone who has hyperplasia. You are decreasing the number of abnormal cells, hoping to buy years and years and years of normal functionality, because the person who had hyperplasia had years and years of normal functioning abnormal parathyroid until the glands grew large enough to produce so much extra PTH that was problematic, right? So you're reducing the numbers, you're turning the clock back and buying years and years of normal function, right? And so you have to make an assessment during surgery, how much of a gland you want to leave behind. And what you're trying to do is you're trying to balance between having enough parathyroid function to live a normal life and buying enough time before it grows large enough to give you trouble. That's why you use the smallest gland that has the slowest growth rate. All right? And so the steps of the surgery are essentially the same to begin with. Let me go in again. So make the same incision, separate the skin. You get a PTH level at this point. Retract the muscle, retract the breathing tube, and now you can see both parathyroids are now larger, right? You go to the other side and you look and you find this one larger, this one is a little enlarged but not so much. So the right lower one in this particular case is the smallest of the 4 glands that are abnormal, right? You take out the 2 on the left, you take out 1 on the right that was larger and leave the smallest one in place. Maybe do let me actually zoom in for you. What I do is put a little titanium clip at one end of it, not only to identify, I biopsy a small portion, right? And send it to the pathologist. That way I can confirm that I found the 4th parathyroid, just in case this grows in the future and needs to have surgery. And then close as I would otherwise. And then the treatment, I draw it in the same way. The patients need more calcium monitoring in this particular case. And then usually I put them on this regimen, right? Because that 4th gland that was biopsied usually is in shock and will need some time to recover. In any case, that's the basics of it, right? So I'm going to jump into the questions you guys have. There we go. Kathy Gold. I have parathyroid hyperplasia. Apropos, Kathy, I just talked about it. In 2017, I had surgery and 2 parathyroids were removed, one having an adenoma on it. Great. The surgeon put staples in the 2 remaining parathyroids in case he had to operate again. Okay. I'm now having problems and symptoms again. I asked my surgeon why he didn't remove 3.5 glands when he did my surgery, and he told me that it isn't something that they do anymore. He's sending me to a surgeon who trained him. He referred me to me as a patient in the gray zone and said he was not comfortable operating on me again. I also have hypothyroidism and several nodules and goiters on my thyroid. What are your thoughts on this? My last labs were calcium 10.3, PTH 88. Okay, so Kathy, I'm sorry you're going through this. I think what threw him off is the fact that you had an adenoma on one of the glands, right? And as I showed you just on the thing, sometimes you have adenomas going on the background of hyperplasia. And so that can cause issues, that can cause problems, because that may make the person think that you may not necessarily have hyperplasia, you may have an adenoma. It's a confusing thing. You have to make decisions in the operating room, and that may have misled him or her to do something that wasn't what you would call a standard, right? And that happens. Parathyroid surgery is hard. You have to make decisions in the operating room. You're trying to have the best interest of the patient. At the same time, you're trying to give them as much improvement while not causing complications and problems. But if your doctor, your surgeon, did find all 4 glands, biopsied all of them, right? So, and put clips on them, then you know where the location of the last 2 remaining glands are, right? Now, you're not in the gray zone because you have high calcium and high PTH, so you have persistent hyperparathyroidism, right? Or recurrent, persistent. Depends on how your numbers went, right? And so you still have this disease and you still need to address it, right? And yes, you should see an expert parathyroid surgeon. The reason I try to tell people to have their parathyroid surgery by someone who has expertise is that that person is the best person to go back into your neck. They know your anatomy, they've been there. If they make notations like me, they have a roadmap of what to do, but if they need to go back in, because I do that roadmap because I don't know which patients may have a recurrence, right? I need to be ready, so 10%, can have a recurrence roughly. And so I need to be ready that any patient that I operate on may have a recurrence and I need to go back in. I would be the best person to do the surgery again, if that's the case, because I know what I'm in for, right? In any case, so your surgeon is saying you should go to a more expert surgeon. I would take that advice, right? But if the biopsy showed that those two other glands that he put a clip on are parathyroids, then the new surgeon knows where the parathyroids are, can on a CT scan see where those clips are, right? And do a surgery that directed and is not going all around looking for them, is directed. The one caveat is you don't know which one of those two glands has survived the previous surgery. So the difficulty in what you're going to be facing is that you definitely need PTH testing during surgery, without exception. I mean, that's a sine qua non of this repeat surgery for you, because if both of the parathyroids are functional, right, and they remove one of them, right, and try to find the other one, and let's say they're successful, right? They're successful, they find the other one, and they decide that they're either gonna take it out and reimplant it, great, right? Or they wanna leave it in place, right? Cut it in half perhaps and leave it in place. You want to know how much functioning that parathyroid gland has after they've taken out half of it, right? Because if they check your PTH, it starts at 88. They take out one of the parathyroids, right? They go to the second one, they see that it's enlarged, they see where the blood vessels are, they cut it in half and check your PTH level. If your PTH starts from 88 and after that cut it in half at 5, 10, and 15 minutes, the PTH goes from 88 to 22 to 18 to 16, it's coming and plateauing. That means that remaining half is functional and doing okay, and you're gonna be fine, right? If on the other hand, the PTH goes from 88 to 12 to 5 to 0, that means that last remaining gland may not survive. You should reimplant a portion in the muscle to give you a better chance of having parathyroid function. If on the other hand, they take both of these parathyroids, reimplant half of one in the muscle and check your PTH level, and your PTH goes from 88 to 22 to 18 to 16, it's not that reimplanted parathyroid that's doing it. There must be a fifth parathyroid. Now, if the numbers are low like that, that may be okay. They may choose to not reimplant. They may say, okay, you already have another parathyroid that's low level functional. That's you're fine. Let's not reimplant and you're okay, right? That's important. Or if the PTH goes from 88 after reimplant, or they take the fourth one on before they reimplant, it goes from 88 to 40 to 38 to 22, then you have another gland that's really functional. It's even worse. If it goes from 88 to 60 to 55 to 53, then you have another overfunctional. That's when your surgeon should search for the fifth parathyroid gland, okay? So there's a lot of complexity, and the experience and knowledge of your repeat surgeon is exceedingly important in doing the right job for you. Best of luck, Kathy. It's a tough situation, all right? John Feeney. Hi, John. You've been most helpful, and I look forward to having my surgery with you in the near future after everything in the country calms down. Absolutely. And good luck, everyone. Please take care of yourselves. My question is, what is the relationship between normal hormonal hyperparathyroidism and hyperplasia? And that's a very good question. So, John, again, hyperplasia is when all four glands are slowly growing, right? So this is two representative glands, slowly growing, right? Because there's a genetic base to it that causes the glands to grow. Instead of, normally our glands grow to an adult size and they stay that size the rest of your life. But in patients who have hyperplasia, these glands continue to grow, right? And as they grow, they produce more PTH. And as they produce more PTH, their calcium level comes up. but the growth rate of these glands generally are relatively slow, which is why if you have this thing and you're born with it, you may present with your first symptoms at the age of 50, right? That's a very slow growth rate. If you present with your first symptoms at the age of 75, it's an even slower growth rate. If you present at the age of 30, that's a faster growth rate. So the age matters in this particular case, right? So as they're slowly growing, they produce more and more hormone. The amount of hormone they produce is not dramatically high, right? But it's a slow, gradual change, right? So the symptoms are slow to come on, right? And it's hard to figure out these patients until they get to a critical point of like, right? So generally, in all comers, let me flip this around. There's studies on this actually. So when you look at all the patients in aggregate, you have 5% who have hyperplasia, and then 85 one gland and 10% two gland. But in patients who have PTHs less than 100, right? And the normal hormonal patients fit into that category. Kathy Gould's numbers we just looked at with PTH of 88 fits into that category. When your PTH is less than 100, the chance of having multiple glands be abnormal goes from 15% to 25%, right? Before it was 10% of this and 5% of that. Now, in aggregate, it's 25%. So there's a 25% chance of having multiple gland disease, all right? So the chance is more for people who have normal hormonal hyperparathyroidism. Chance of having multi-gland disease is much higher than it is otherwise. Very good question. Now let's get back to your question and see what else you're asking. All right. Also, what does the recovery look like for hyperplasia patients? That are supplements required for life? Very good questions. Recovery is a little bit different. You know, you've had a lifetime of adjustments, right? And I find that these patients, their body is constantly been compensating for this slowly growing. So the compensation is happening slowly for these things. So they've been put up with it until they get to a critical point of like, the body's just like, I can't compensate for this much anymore. I've compensated for too many things, right? So you get symptoms. And then the recovery is, I find, a slower recovery because you not only have to recover the calcium imbalance, but you have to recover all the compensations that these patients had. So the compensatory mechanisms also are affected, and the patients have to go through a longer period, And so when you go through these support groups and you talk to patients, and some patients say, hey, I woke up and in the recovery room I was feeling better, I'd say that's a patient who had an adenoma, right? Hasn't had it for too long, right? And most likely that adenoma was causing rapid changes in the bone, so they were getting aches. So I find the patients who have bone pain, the patients who in the recovery room will say, oh my God, my back pain is gone, my wrist pain is gone, right? Because the PTH is now down and they're not getting resorption of bone. That's they're feeling as pain in the bone, right? Those are the patients, but not every patient fits into that category, unfortunately, right? And that's why on the support groups, you'll find patients who have symptoms that go on for years, sometimes 6 months, 8 months, 12 months, maybe even up to 2 years, right? Where patients take that long to have improvement of symptoms, sometimes probably even longer. And that really, I think the recovery of symptoms has to do with a couple of things, right? Based on what I've seen. It has to do with how far away your calcium is from your normal. So if your normal is here and your calcium is just slightly elevated above it, your compensatory mechanisms have not been dramatic, right? But if the shift is this wide, right, you've had to compensate a lot more. And then also how long you've had to do that compensation. So the longer you've had to do compensation, the longer is the recovery of it. And then in terms of taking supplements for a lifetime, I am not a fan. I'm not a fan of supplements, actually. I'd rather you get your supplements, your nutrients through natural foods that you eat. That's how you've evolved. Your intestines have evolved to get food not from high dose of a single element, but rather multiple elements in a vegetable coming into your body, So calcium coming into your body, into, and dairy is a less evolutionary thing. The more evolutionary thing was getting calcium through green leafy vegetables, right? Eating leaves and from all over the place, right? And so I really like my patients trying to transition from supplements to foods to get their calcium, vitamin D, and magnesium and all the other nutrients that they need, right? So I'm not a fan of doing a lifetime of supplements, but for patients who have hyperplasia, who have surgery, and that last remaining parathyroid does not recover, they do have to take supplements, because natural sources of calcium are hard to get enough calcium for the body, because your absorption mechanisms are poor. You can't, without a parathyroid gland, you can't turn 25 hydroxy vitamin D to 125 dihydroxy. It's the 125 dihydroxy vitamin D that helps you absorb calcium. So without that conversion, you can't absorb calcium. So you need to take recalcitrant, which is 125 dihydroxy vitamin D, and that comes in a pill form. It's a prescription, in fact. So you need that, right? Without that, you wouldn't absorb calcium. You can't live. Your body would go into shock, basically. Your heart would stop, your muscles would spasm. So it's not possible. So you need, for non-functional, you need that. And in some proportion of patients, and most patients do well on taking a lot of calcium and PTH, right? But some portion is just not enough, and that's the portion of patients who have to take injectable PTH. It is something that we as surgeons dread. We try to do our surgery and try to minimize that, but unfortunately, the nature of the disease, the inconsistency of parathyroid disease, the fact that some people have 3 parathyroid glands and some people have 5 and 10 and 12, the fact that some people have hyperplasia and some people have adenoma or double adenoma, all these complexities makes it difficult to guarantee that someone is not going to have this possible complication. So the best of surgeons get this complication, and they all lose sleep. We all, when we get this complications, and I've had it, unfortunately. I the 2 patients that I have it, I remember them all the time. And it is an unfortunate complication. You do everything you can to try to minimize it, but it is a complication that occurs, and it's unfortunate, but it is the nature of the disease that results in this potential, and as you gain more experience, hopefully you get better at avoiding it, but it is almost impossible. If you do enough parathyroid surgeries, unfortunately, you're going to get that, and that's a hard one to live with. But again, you can try to minimize it, and there's ways to address it, and John, that's all I got for you. I hope that wasn't discouraging, but at the same time, here we go. Heather James. Dr. Larian, I had one adenoma removed 10 weeks ago, and most of my symptoms have disappeared, which is great. However, I have new symptoms like muscle, nerve, and joint pain that come and go. I never had these before surgery, and my surgeon tells me it's just my body rebalancing due to calcium levels, which are now normal. Also, all my labs, thyroid, CBC look good. Does it take the body time to rebalance, and are these aches and bone just parts of the problem? They are, Heather, they are. I don't want you to worry, especially with the calcium being low. And now you need to look at the PTH level. Sometimes it's the compensation by your body that now has to recompensate to the normal, right? Get back to the normal. That's the thing, right? And that change and rebalancing gives you symptoms. Sometimes you have some degree of hungry bone syndrome. So your calcium goes down towards your normal level, right? Because the abnormal parathyroid is gone. But your bones are grabbing all the calcium out of your bloodstream, and because you're grabbing it out of the bloodstream, your parathyroid glands try to compensate by increasing PTH, and the PTH itself can give you, that elevated PTH can give you symptoms. So it could be that as well. But it is not abnormal to go through these things, and majority of times they do pass, all right? Moving on, Pat Hallinan Wagner. You told me several months ago the surgery was my need. At that time, PTH was 198 with normal calcium and vitamin D. Scan showed possible adenoma on one gland. Saw an endocrinologist that convinced primary no surgery, just take high doses of vitamin D. Did the vitamin D for about 6 weeks and no changes. 2 weeks ago, had labs done prior to seeing surgeon, but going forward with surgery. PTH now is 9. Wow. How is that spot? Well, with all the virus stuff, figure I will put off appointment. Calcium is high, normal high normal and vitamin D normal. Now what? Okay. So, scan showing possible adenoma. If it's a sesame scan that they ordered and it showed possible adenoma, I'm not convinced, and I wouldn't say, right? But it actually, at this point, if your calcium is high normal and vitamin D is normal and your PTH is 9, I would suggest you do multiple labs, right? Continue to take the vitamin D, right? And I would say maybe 3,000 units a day, right? And continue looking at your labs. If your labs have normalized, right, and continue, your calcium stays in the normal range, right, your PTH stays in the normal range, and your calcium and PTH in the normal range do this thing with each other, right, then I was 100% wrong. You don't have hyperparathyroidism, hallelujah. You had vitamin D deficiency causing your problem. And that would be wonderful, because then you can avoid hospitals, doctors, surgeons, all things that are good to avoid, especially at the time of this corona situation, right? So that's my advice, and hopefully that is the case. Hopefully you just had a vitamin D deficiency. And that's why I try to encourage patients who have low vitamin D to do a trial of vitamin D, because even when the numbers look like they're in the direction of a particular diagnosis, we could be wrong. We as doctors could be wrong, and that's important too for all of you to note, right? As you're trying to help yourself. Natasha Moore. I was told I have hyperparathyroidism since my labs showed high calcium and high PTH. Sesame scan showed probable right adenoma, but ultrasound was negative, and that could be the case. You know, if the parathyroid gland is behind your thyroid, your voice box, or behind your chest bone, the ultrasound may not be able to reach it. Okay. And he was saying something about a thyroid nodule. One of the things that bothers me the most is the heat intolerance. Would this be caused by hyperparathyroidism? I do have some patients that have night sweats and some heat intolerance, but it's more often a sign of parathyroid overfunction. So you'd have to look at your thyroid labs to make sure. Would this go away? You know, in the patients that I had, I didn't have thyroid abnormality, and a lot of them, the heat intolerance did go away. But in a few, it didn't. And some people just are heat intolerant. My mom and I, even though I'm very thin, I'm very heat intolerant, you know? So when I sleep at night, my wife puts 2 blankets on her, and I have a sheet, and I have to sit next to the window that's open, and she wants the fireplace on, right? So our temperatures are different, you know? And so my mom is the same way. My mom, we were in Toronto on New Year's Eve. It was like, I don't know, negative, some awful temperature, and she had to have the window open, right? We were all freezing, there were icicles forming on us, and she just had to have the window open. That's how she is, right? So sometimes heat intolerance is the nature of your existence, right? In any case, you know, also ask, is thyroid storm a common thing after surgery? No, fortunately not. You know, thyroid storm for someone who has Graves' disease is a potential. Some people who have Hashimoto's, if they get a Hashimoto's attack, the initial stage of attack can cause inflammation in the gland, and the gland can release a lot of thyroid hormone, and then it can recover. So that can happen too, but it's very uncommon, fortunately. Lala, hi Lala. I had my consult with you on March 10th, looking forward to scheduling surgery down the road, so I have a question I have heard debated over and over again. Does primary hyperparathyroidism have any effect on sinuses? For years, I had what I thought were mild allergies. In the last years, since moving from a lifetime in California to Savannah, Georgia, my sinuses have become a huge issue. Had allergy testing that was all negative. CT scan was clear, slight deviated septum, thickened nasal turbinates. Mild, they say. I've suffered tinnitus on and off since December, mostly right ear, really bad right now, and on and off. A very mild hearing loss in the right ear. This was just discovered this week. I had no clue. Well, okay, I'm having an MRI to look for an artery neuroma. panicky about this. Now I know hyperparathyroidism can cause... I know that hyperparathyroidism can't cause that, but what about sinus tinnitus? Well, tinnitus is almost always a manifestation. Tinnitus means ringing in the ear, a manifestation of some degree of hearing loss. So if on your hearing test you show that there's a slight loss on the right side as compared to the left, and you have ringing on that side, that makes sense. I actually have that as well. Too many concerts when I was younger. A lot of loud music. I'm the Walkman generation, right? That first generation Walkman that came out. I put it on and I was blasting it as much as I could. So I destroyed my ear. Who knew, right? In any case, so I do have tinnitus. And I discovered it about 15 years ago. And the first year I had it was going nuts because I couldn't stop thinking about it. And then once I figured out what's wrong with me and I have hearing loss, actually it's more than that. It's 21 years ago. Time is flying. In any case, after I figured out what it is and I stopped commiserating over it, after I stopped thinking about it all the time, the sound diminished because it's not a real sound. Tinnitus is your brain it's like almost like a phantom limb syndrome. When people have amputations and still feel their arms, when you have hearing loss, your brain still wants to hear, and so creates this sound in the areas where you have absence of information coming in. So it's not a real sound. And so when I stopped paying attention to it, or powering it up and stressing about it, going to bed saying, am I ringing? Or in the morning waking up, did the ringing wake me up? When I stopped doing that, the sound very much diminished. But fortunately, acoustic neuromas are very rare, so your MRI will show you, and hopefully it won't be a problem. In terms of allergies, I haven't seen a connection between hyperparathyroidism and allergy symptoms. It's just not a common enough finding between the two patient populations, in my experience. I don't know what to do or even take. Well, I would suggest that you do an allergy test to see what you're allergic to see if there are things you can avoid. First, rinsing your nose with salt water every day in the shower will really help, because whatever's getting in your nose and giving you sinus issues is the problem. As a secondary measure, you can use nasal sprays. They have steroids in them, but they don't get absorbed in the body, so that may be the next thing. Again, if you can manage it with allergy testing, avoidance therapy, and rinsing, that would be a better choice. Nose spray is the next choice. And the last thing would be antihistamine pills on a daily basis. I'm not a fan of pills, so if you can avoid them, I would do that. But you can get control over this. It doesn't sound like you have terrible allergies because you're not having frequent sinus infections. So this is something that you can very well control with these conservative measures. Even a HEPA filter in the bedroom running all the time also can help. Feeling lost these days. You know what? These are overwhelming days, Lala. Everybody's feeling lost. And I understand what you're, not only do you have your own personal medical history going on, the world is on edge because of the coronavirus issues and the uncertainty and the rapid movement and change on the economies. And so I certainly understand how this is creating increased panic, but you're going to be okay. All right. You'll do the MRI. You'll see that's negative. You can get a handle on your allergies, and the parathyroid will take care of it. Okay, my dear. And when this corona phase passes, we'll take care of that. Let's see. Is it coincidence my calcium goes up that this worsens for me, considering anxiety cause hearing tinnitus issue? Yes. Obviously when your calcium levels go up, that change can give you symptoms, right? And as I was saying, as I was stressing about my tinnitus would be louder. As I stopped stressing about it, my tinnitus was louder. So the stress of these times, I find a lot of patients are calling my office and stuff and complaining about their tinnitus as well. Stressful times always create more nerve-related symptoms, and tinnitus is a nerve-related symptom. Not sleeping, constant health anxiety, panic, working with a therapist. Thank you. I'm so sorry you're going through all this, but trust me, you're going to be okay with all this. All the things that I saw and see for you are not big dramatic changes, and you'll do the MRI and see that you don't have an acoustic neuroma, and hopefully that's the case. Again, it's a very rare tumor, so once you have that certainty, I think that'll put you at ease. Okay, my dear? Best of luck. Call me if you need any help. I'm happy to talk to you. Kimberly Ann, can chronically low vitamin D cause high PTH? Yes. Vitamin D is interesting because vitamin D has a loop where it goes back to the parathyroid gland and suppresses the gland, right? It suppresses it a little bit from producing PTH. It suppresses it also from not growing. So when vitamin D is absent, the gland grows. And so when people have vitamin D deficiency, the gland continues to grow and it produces a bit more PTH, and that can cause a secondary hyperparathyroidism, which is what we suggest when patients have low vitamin D levels and have some hyperparathyroid symptoms and laboratory findings of showing PTH that's elevated specifically, maybe mild elevations of calcium. We think, let's give this patient a vitamin D replacement and try to see if we can normalize it, right? And that's definitely a possibility. If I get my vitamin D back up, can this all be corrected? Absolutely. Oh, and you say my calcium is always normal, around 9. Yeah, Kimberly Ann, absolutely. That is the thing to do. I would focus on that primarily because you could have secondary, and by correcting your vitamin D, you can go back to normal and not need to deal with us surgeon types ever, okay? Which is always a good thing if you can avoid us. Eve Thurkel, sorry, you see half of my face. I'm trying to read the screen. You know, at home I have less things and less ways of doing this thing, so the get around is unfortunately for you to see half my face. Eve Thurkel, how is people's immunity affected by primary hyperparathyroidism, especially in relation to COVID-19? Well, you know, I think hyperparathyroidism puts an undue burden on the patient's body and creates an inefficiencies. And you know, hyperparathyroid patients do have medical issues and complications that develop. I have not seen increased frequency of infections, fortunately. Now, I can't tell you with certainty that means that you're protected against COVID-19 or not. I'd say I haven't seen increased amount of infections with the patients, viral or bacterial, and so probably the impact on the immune system is less so than it is on other systems in the body. So I think hyperparathyroid patients are relatively safe. Having said that, in all the reports that I read, in all the data, and looking at the data for COVID-19 and coronavirus, there's a lot of uncertainty about this particular virus, and I don't know where the uncertainty is. Is it because the duplication rate is faster and grows? Is it more infectious? I know that when patients have COVID-19, the coronavirus infection, the amount of virus in their throat is significantly higher than other types of infections, and so that's an alarming thing about this particular virus. We don't know if this virus has a higher, because it has a higher duplication rate, copying itself. Does it have a higher mutation rate so it can transform to other more aggressive viruses and cause other problems? You know, there's a lot of things that we don't know. So I'd say the safest thing to do is not to overestimate your immunity and stay home and to do the avoidance if possible for you in your life, okay? Especially if you're older, especially if you have other diseases, if you're a smoker, if you have lung disease or heart disease or any of those things, diabetes, which obviously affects your immunity, then you should just be smart. I think parathyroid issues in and of themselves probably not as big an impact on your immunity and viral infections, but it's at this uncertain time, it's better to be safe. And I'm not trying to scare you, I'm trying to actually empower you to make a smart choice for yourself, right? So not enough information to know about the virus, not a clear connection, obviously not enough time to us to make a connection between hyperparathyroidism and as it relates to the virus, right? Nobody knows that, you know, it hasn't been around long enough for us to know, all right? Hopefully that answers you, Eve. Nancy Leonard-Sherman. Is hydrochlorothiazide, is that okay to take for hypertension if one has hyperparathyroid disease? Not the best choice, right? Hydrochlorothiazide is called a calcium-sparing diuretic, means that it makes you pee fluid out of your urine, but it doesn't let you go of calcium. So if you already have elevated calcium and you take this, you have more calcium in your blood, right? So not the best choice. It would be best until you have treatment for your hyperparathyroidism to use another diuretic or another blood pressure medication, right? That would be my advice. Now, There are times that people use it because they are forming massive amounts of kidney stones, so they try to decrease the amount of calcium in the urine to prevent the kidney stones, and that's a balancing act that you have to work out with your urologist and your with your endocrinologist and endocrine surgeons. You got to kind of have to come together to figure out the perfect time for surgery and what to use to prevent the kidney stones and so on and so forth. A complicated equation, but that's what I would suggest. All right. Trends and glitz. Normal calcium now, osteoporosis. Negative 2.6, yes. Parents had 2 parathyroid removed. Help. All right. Well, it's not the fact that your calcium is normal. It's that relationship between your calcium and your PTH that matters. So I would suggest that you check, especially if you have a family history of hyperparathyroidism, that you should check your calcium, your PTH, and vitamin D. And I would say that you should do it on 2 separate occasions, at least 1 week apart. You should also do a 24-hour urine calcium check to see how much calcium you're putting out in your urine. Okay, because if you already have osteoporosis, and if you have this condition, you have a very good chance of reversing a lot of the bone loss that you've had. So we know in patients who have hyperparathyroidism and get treatment that their bone density improvement occurs 100% of the time. Right? Based on a study done at Columbia, 100% of the patients had improvement in their bone density, and that improvement in bone density lasted. So when they checked their bone density, even 15 years after getting hyperparathyroidism surgery or parathyroidectomy, their bone density was 10% better than before surgery. So even 15 years later, you can have improvements, right? So you can have measurable gains. So do calcium, PTH, vitamin D on 2 separate occasions, right? So that way you can see the relationship at a minimum. And that if that relationship shows that there is a lack of suppression, so if your calcium is in normal, let's say your calcium is on the mid to upper range of normal and your PTH is high, both times, and your vitamin D is normal, and that's called normal calciumic hyperparathyroidism. And in the setting of osteoporosis, you should have surgery, right? So you need more data points to be able to answer that. And if this is not clear enough, email me at the office and I'll try to figure this out for you, okay? Sasha Gramland, can high calcium cause petechiae? I have paresthesias and petechiae, CBC, okay. I have not seen that. I haven't seen that. But, elevated calcium levels of prolonged can affect blood vessels. It can cause stiffening of the blood vessels, which is one of the reasons that people get hypertension or high blood pressure. So it can cause fragility of blood vessels too, because they're not flexible, they're stiff. So a stiff blood vessels is more likely, especially if it's a tiny capillary, I would theorize that it's more likely to be able to rupture and give you petechiae. So even though I haven't seen it, I can on a theoretical level see how that connection could exist. All right, Daniel Rossi. The last question that came in prior to us starting, and there are some questions that we had during this. So let me get through Daniel. Good morning, and thank you for your help. My pleasure, Daniel. 49 years old, as am I. I had a parathyroid adenoma removed in July of 2016. The other glands weren't checked. The day after the operation, calcium and PTH were 8.5 and 6.4, respectively, from 11.2 and 190, about a month before. Awesome. When I was diagnosed. During the 3 years following the operation, calcium had most frequently been normal or high normal, with PTH slightly elevated or high normal. And vitamin D constantly low, with very little tolerance of any significant supplementation. Since a few months, I've been having a few mild symptoms, and most recent labs are November 25th, calcium was 10.8, PTH of 33, vitamin D 17. December 4th, calcium 9.8, PTH 64.4. February 2020, calcium 10.3, PTH 64. Daniel, that's a tough one. Does this look like a recurrent hyperparathyroidism? If so, there is any chance that my symptoms will remain mild before the parathyroidectomy. Some of them had gotten pretty severe. Good question. So let me first say that you should do another set of labs, and this set of labs should include a couple more things: calcium, PTH, calcium PTH, 25 hydroxyvitamin D, and 125 dihydroxyvitamin D. Because if your 25 hydroxyvitamin D is low, 17 like the one you had in November, but your 125 is elevated, any calcium supplementation is going to transfer your 25 hydroxy to 125. And 125 is the active form and the form that gives you symptoms. That gives you more reason to believe you have persistent hyperparathyroidism rather than a vitamin D deficiency causing it. I would also do a 24-hour urine calcium measure, because if you're putting out a lot of calcium in your urine, that means your kidneys are telling you these calcium levels are too much for your body, and they're trying to compensate by putting that out. Right? That also gives you more information to help you decide what you should do. And yes, based on the numbers you have, it does look like it, but I would personally do these other labs that I'm telling you to tell you with more certainty if that's the case. Is there any chance my symptoms will remain mild? There is a chance. The issue is that you're a young man. I have to say that because I'm 49, right? So you're a young man. You have a long life ahead of you, and there's great uncertainty about progression. So if you choose to not treat this, right, and to monitor it, then I would say you have to, on a regular basis, do bone density studies. Every couple of years, you got to do scans to make sure you're not forming kidney stones, monitor your kidney function, and so on. And that way you can see the progression of your disease, right? And if you're not having symptoms, I would also really encourage you to be super active, be athletic, be active, because you're trying to counteract a slowly progressive disease. You know, I find the patients that present like yourself, that have one big adenoma and they come back and they have numbers like you, if the laboratory tests that I'm suggesting confirm that it's persistent hyperparathyroidism, most of them have hyperplasia. And let me flip this around. And I find most of those patients fit into this category, right? That they had an adenoma on a background of hyperplasia. And that's why when they took this one out, these three had a chance to start slowly getting worse, right? Now, the other thing I suggest is that you actually do either an ultrasound or a 4D CT scan, because if your other three glands were not assessed, right? So if your surgeon only came here and took this out and didn't take a look at these, and you do another scan and you find another enlarged parathyroid, then you don't have hyperplasia, you potentially had another adenoma that has developed. That means you fit into that 3 to 14% that had a recurrence. And that's an easy surgery where you can have this removed, right? And boom, you're good to go, right? And another easy surgery, and you can forgo all the issues and anxiety and problems that can arise from having another surgery or having persistent hyperparathyroidism that you have to live with for the rest of your life. All right, Daniel, hopefully that helps. All right, I'm gonna go to the questions that came up as we were talking. Corinne Terrell, 2 of my parathyroid glands started working after a year and a half. So that's great news, and thank you, Corinne, for sharing that, because that's encouraging for people who go through hyperparathyroidism surgery and are concerned when their glands are, especially when they have a 4-gland procedure and they have low functioning parathyroids. Sometimes it takes a long time for those glands to really be able to reconstitute their vascularity, blood flow, and really get themselves going. So hearing someone having gone through that and sharing their experience is extremely helpful, and I can't thank you enough, Corinne. Right? Encouraging for other people who are going through this thing. Bobby Jean, good morning from Pensacola. Hello, Bobby Jean. Hope you're well. Hopefully you're avoiding the spring breakers. In any case, Liz Carter. I had a partial thyroid lobectomy and 1 parathyroid removed due to goiter 8 weeks ago and felt good for 3 weeks. Just had a follow-up blood test. PTH is 8. Corrected calcium is 2.63. TSH is 4.4, and I feel dreadful. Okay. You're going to have to give me the units, my dear, because I don't know what your units are. This is Liz Carter. So TSH is high. That means you need more supplementation. That's an easy one, right? In terms of your calcium and PTH, it's I think the easy thing to do, Liz, is, I know you have concerns for COVID-19, and you say my appointment with the consultant, so I'm assuming you're calling, you're messaging me from England. So if this is the English units, your PTH and calcium are both high, it seems, right? Based on my memory, if my memory serves well, you're both a little bit on the upper side of normal or high. I think that you're not going to be able to treat the parathyroid at this point, all right? I think you can improve the TSH by taking higher doses of levothyroxine, right? And that you can do by just calling your doctor and talking to them on the phone. You don't need to go to the appointment. You just call and talk to them, right? Just like I have, every day I have video consults with patients, right? Patients call me, I get on the phone, we do a video thing like I'm doing here and answer the questions. That's responsibility and obligation of us as physicians at this point. Just because we can't see you, it doesn't mean we can't help you. So I would insist that you do. In fact, it probably is better for your doctor for them to do a video consult, because then they don't have to be themselves exposed and their staff exposed to people who may have viral infections, right? But it's an easy thing to do, easy. And I absolutely enjoy it. Just call your doctor, be forceful, and try to get an answer. And if your endocrinologist or surgeon is not answering, your primary doctor can answer this question and change your dosing. But that's the first thing I would suggest doing, okay? First and foremost, right? And then reassess, because you just had surgery, your parathyroids could be affected by the surgery. Fortunately, you have functional parathyroids, right? They're not underfunctional. And they may ease out over time and your parathyroid may normalize and you may not need anything else, right? But you definitely need to change your thyroid hormone dosage. Pamela Newcomb Santos. Hi, Pamela. Nice to hear from you again. Last labs, calcium 1044, PTH in the 90s, vitamin D 68. Yes, my dear. Hyperparathyroidism. What's your question? I think you and I need to speak. All right. I have Sasha Louise. I have paresthesia, which I believe is linked to calcium levels. My doctor told me it can be, as it's not seen in high calcium levels. Yeah, I mean, yes, but your doctor is making a mistake. Your doctor is thinking you're talking about low calcium levels, giving you numbness and tingling, which happens in the fingertips or around the lips. If you're having numbness and tingling in one side or another, that could either be nerve issue, or which can be exacerbated by high calcium levels because nerves malfunction. So if you already have a little bit of a pinched nerve, this can cause it to be very symptomatic. So it could be related, okay? Lisa Gonzalez, dear sir, will you continue doing parathyroidectomies during these troubled times of COVID-19? Whatever your decision is, sir, I'm quite certain that the health of your patient will be first and foremost. May God bless you. You know what? So the guidelines that we're getting is that if you were to delay the person's surgery for a month, would that seriously affect their life and cause problems? And so for parathyroid patients, that's what I would say. If their symptoms are progressing rapidly, they're getting more issues and so on, I can potentially do that. Unfortunately, I have access to a surgery center. I don't have to take patients to a hospital to do this. And the surgery centers have much less exposure. And at the surgery center, they're taking a lot of precautions. It's a more controlled environment, both in terms of staff and the patients, right? So, as a surgery center, we can't say an ill patient we shouldn't operate on you should be addressed at a hospital, but a hospital can't do that, and that's why surgery centers are built, to treat the less acute, less problematic, less ill patients. That's what it's designed for. So that possibility exists, okay? But it all depends on what's the ramification? Is it worth the potential risk of exposure that you may have? Pamela. Again, I have a 4 centimeter growth on the outside of kidney, bladder, not emptying. Odd you mentioned that. All right, let's talk, Pamela. I need to see what's going on. What else is going on with you? Sally Whitehead. Hi, do you know about an alternative test for bone density, radiofrequency echographic multispectrometry? It uses ultrasound, marketed by these people in the UK as more reliable than DEXA scan. I know the DEXA scan is very good for wrists and leg bones and not so accurate for the spine, right? And so that's why the new guidelines have actually included doing either a CT scan or other forms of modalities for the spine to see if there is fracturing in the spine or loss of bone. And so I'll look into what you're saying. I don't know enough about it, to know. Pamela, they haven't located the 2 remaining parathyroids. Have they done, Pamela, the 2 options I would suggest is a 4D parathyroid CT scan, and if that's not fruitful, then the choline PET scan that is available in not too many places, unfortunately. Don Mary, this is very helpful. Are there certain known toxins that increase the risk of developing an adenoma? No, there are no known ones, unfortunately. Only radiation exposure. So if someone had radiation treatment for, a lymphoma in the neck, years later developing a hyperparathyroid or parathyroid adenoma, potentially even parathyroid hyperplasia. Bobby Jean, hello again, Pensacola. Have you ever gone in to remove parathyroid adenoma and found nothing? My sesame scan was positive, my ultrasound was negative, I'm awaiting surgery and I have this fear that they won't find anything. Is it a legitimate concern? Yes, it is. I mean, you're thinking, and that's great. You're thinking about this thing. But let me just put it into perspective. It all depends on your numbers, right? So if you have a calcium of 11 and a PTH of 200, no, I've never had a patient that have gone in those numbers and not found an abnormality, right? But if your calcium is high normal, 9.8, and your PTH is 40, right? And you're having parathyroid symptoms, that's where the gray zone has come in. I haven't found any patients who now there are patients that have not as high a number as I mentioned. Let's say a calcium of 10.3 and a PTH of 60, right? The PTH number is not high, which means that if they have a parathyroid adenoma, it's not a very large parathyroid, right? And in those situations, I have seen situations where you go in and you may not find it, and potentially that is when they have an ectopic parathyroid. So the parathyroid that instead of being in the normal area behind the thyroid was all the way down in the chest, and the scans didn't find it. So if the SESTIM-EV scan is not, if your numbers are such as I was saying, like calcium of, slightly elevated and PTH slightly elevated, and the SESTIM-EV is saying potential, not a clear picture, then I would suggest you do also a 4D parathyroid CT scan to improve the certainty of the location and go from there, and just talk to your surgeon to see if you can do that, and talk to them about how convinced they are that the SESTIM-EV is okay. If they've done the SESTIM-EV scan as a first thing after ultrasound, I'd say that they don't have a lot of reliance on 4D CT scans, and so that's their mode of thinking. But I really don't like the SESTIM-EV scan as a primary mode, and I usually try to do more. Let's see. All right, let me get back to you. All right, okay. Hopefully that helps. But improve your confidence by doing a 4D CT scan. Okay. Sarvi, hi, a friend just came on, or has been on perhaps. Joe Carol Hughes, Kaborowski, feeling so discouraged. Surgery in October 2019. Pathology showed 2 normal parathyroids removed on the right side. Secondary surgery February 2020, 1.5 hyperplastic parathyroids removed on the left side. The second surgeon surmises that the first surgeon left a hyperplastic gland on the right despite pathology report. Second surgeon will not reoperate on the right side until next October due to scar tissue. I haven't had repeat labs yet, but I'm hoping labs show I still have hyperparathyroidism because I still have all the miserable symptoms. Thoughts? Hard to answer, Joe. I mean, during the first surgery, 2 parathyroid glands were removed on the right side. During this surgery, another 1.5 parathyroid glands were removed on the left side. If your surgeon on the second surgery didn't go to your right side, then the scarring on your right side is as is, right? I would wait a few months for the scarring to settle, but I don't think I would wait till October, potentially sooner. But I would highly encourage you to do the surgery with someone who's doing intraoperative PTH testing, all right? Absolutely, without exception, because you just can't do a good surgery at this point without PTH testing, all right, my dear? Hopefully that answers your question. All right, Jeanette Thornton. I've had kidney stones 3 times. The last 2 times was 6 months apart. 7 millimeter, had to have it blasted. Doctors checking parathyroids. Have only had 1 test. To date, vitamin D was 22, calcium 9.9, 24-hour urine calcium was 562. Wow. I checked old medical records and calcium used to be 9.5, 9.7. Since kidney stones, my calcium seems to be higher. But it's not a dramatic shift from 9.7 to 9.9. It's not. I know 9.9 are normal, but do you think I could have the tumor? I do. It all depends on your PTH level. My last appointment was canceled because of the rice. Did they get my lab results for second 24-hour urine test? Is it still very high? Yes. Jeanette, you need calcium, PTH, and vitamin D drawn at the same time. And I would do it more than 1 time. I would do it twice, 1 week apart, because that'll tell you if there's an imbalance between your calcium and PTH. I have lots of, in fact, some of my best referrals are actually urologists who are treating kidney stones and send these patients who get recurrent kidney stones, right? Because, urologists, when someone has kidney stones, they do a calcium check, and if the calcium is normal, most urologists say, okay, well, you don't have hyperparathyroidism, sorry, we don't know the reason, that's it. But some of the ones who have educated themselves on the subject know that you can have normal calcemic hyperparathyroidism still causing kidney stones. And so these are the patients, doctors who send me, and their presentation is similar to yours. So it's the PTH and calcium relationship that tells me in these particular patients if they have hyperparathyroidism. So I would highly encourage you to do those tests, all right, especially at such a high PTH, high calcium in the urine that you have, okay? Good luck. Lisa M. Olson, I had a double parathyroidectomy hoping to be cured, but I'm not. 16 months post-surgery, I still have very high PTH, but have managed to stabilize my calcium and vitamin D. Vitamin D only recently increased, but still have a high PTH that has also fluctuated. I'm still experiencing all the same symptoms. What's not making sense is I've had lower vitamin D and lower PTH now. My vitamin D is the highest it's been. My PTH is still high, just can't seem to get to the bottom of what's causing it. Histology has shown hyperplasia or parathyroid gland on the parathyroid gland and right thyroid nodule, hyperplastic. Well, Lisa, I mean, if your vitamin D is normal and your calcium is in the normal range and your PTH is elevated, then I would also suggest doing is doing a 24-hour urine calcium, right? Because if your 24-hour urine calcium shows that your calcium level in your urine is low, that means you're not absorbing enough calcium. You need more calcium in your body, right? If on the other hand, it shows that your calcium level is either normal or high, especially if it shows that the calcium in your urine is high, then you have persistent hyperparathyroidism and you need to have that treated, okay? And that's the strategy I would use. There's on my website, there's a parathyroidmd.com, there's the worksheet that you can use to kind of guide you as to what labs to do and how things to do it, but that's the strategy I would take. Okay, Jane Reese, PTH before surgery 209, calcium 11.3, 2 removed. After PTH 79, calcium 9.7, 2 months now. PTH 111, calcium 10.4. Oh, I'm so sorry. Symptoms back, second surgery to remove, third and maybe half of the fourth one. Should I wait to see if the test improve? I would wait a minimum of 6 months, more like a year, to do the second surgery, okay? Because sometimes these numbers normal. Sometimes the adjustment period gives you some of these issues, okay? So that's my advice at this point. Hi, Kelly Flanagan. Jade Louise. Hello, I have primary hyperparathyroidism, awaiting a second surgery. I have normal vitamin D, slightly high calcium, very high PTH. Okay, but I'm currently folic acid deficient and I've started taking some. Can I take vitamin D, vitamins to boost my immune system at the moment? Yeah. If your vitamin D is not normal and not on the upper side of normal, but in, low normal or mid normal range, yes. Is folic acid deficiency related to hyperparathyroidism? Not that I've seen. I don't think there's any relations. Good luck. Just if you're having these symptoms, try to have the surgery once the virus issues have resolved and it's safe to get it back into the healthcare system. And Taylor, I had surgery in August of barely noticeable, but there I had an ultrasound. Nothing was noted except heterogeneous echotexture of my thyroid. I have Hashimoto's. I'm not sure what to do as my endo was not particularly helpful, nor was my surgeon. I have a small lump over the incision site. So, what you have to figure out is this lump right at the skin or is it deeper? I mean, if the ultrasound was negative, I assume it's in the skin, and what you may have to do is just have that portion of the lump removed by your surgeon just to do a scar revision, okay? If it's deeper, then the ultrasound would have shown it, right? I'm going to ask, silent reflux can cause sinus problems though. Yes. If you have acid reflux and it gets up into your nose, so it goes from your stomach all the way up to your nose, it can cause nasal issues. It's that happens more often in kids and children, less so in adults. It does happen in adults, but less so. But Kelly, you are correct. I stand corrected. Brian, what causes tinnitus? Loss of hearing. I have hyperplasia. Tinnitus, ringing in the ear, is almost always caused by a deficiency in hearing, because your brain still wants to hear, but the ear is not sending that information, so the brain creates that sound. I have hyperplasia, 4 glands, 2 removed. Tinnitus started a year ago. Hyperparathyroidism doesn't directly cause tinnitus, but it can create an increased irritability state, which causes the tinnitus to appear to be louder. Lisa Souza, anything I can do to jumpstart my metabolism after surgery on January 30th? Being active, exercising, Lisa. That's the most important thing. Forcing your body to get going. Suzanne Correa. Suzanne Correa had consultation with you in October. Prior surgery 2016, 2 adenomas removed. Your diagnosis is hyperplasia. Current labs, calcium. I can't say with certainty that you have hyperplasia, but in my experience, most often when patients have a recurrence in this scenario where 2 glands were removed, then the remaining 2 glands usually have hyperplasia. But you say your current labs are 8.6 with PTH up 167. I would say that I need more information. Suzanne, I don't remember the details of your case to give you a good answer or this medium, but I would need to look at your vitamin D, and I would need to look at multiple labs before and after surgery to be able to give you a good solid answer. And I can do a video consult for you if you like. I've already seen you, so easy to do. Just contact my office so I can go through the numbers with you. But I do need more information to give you a more accurate answer. Last but not least, April Dawn Robel. I have recurrent kidney stones. My urine calcium is high. My vitamin D is around 19. My blood calcium was 9.8. My PTH is 86. Doctor keeps telling me different things about taking vitamins, these vitamin supplements. What should I do? I would take roughly about 3,000 to 4,000 milligrams of vitamin D supplements a day. And then repeat your labs in about 2 months, right? Make sure you're taking magnesium. Magnesium helps stabilize things, all right? Maybe 500 milligrams of magnesium a day, divided into two doses of 250. Make sure you're active and exercise and you hydrate well, and then repeat the labs at that point and see what your numbers are. That could give you a better representation, because hopefully this is a secondary hyperparathyroidism due to the low vitamin D, and the PTH level can come down. This is generally the picture of someone who has vitamin D deficiency and has secondary hyperparathyroidism. High normal calciums, slight elevation in PTH, and low vitamin D. So you could very well fit into that category. All right, there you go, guys. That's my time. I'll have to run and take care of my kids before my wife gets super overwhelmed. All right. I wish you guys well. These are very strange times. Take care of yourself. Be smart. Stay away from others as much as you can. Stay away from people, from the parents and grandparents, especially if they have illness. I haven't seen my mom in a month. She had, funny enough, the good fortune of twisting her ankle 2 months ago, and so she couldn't get out so much anymore. She's very social, and so she couldn't get out, and so she's been homebound, and so she's completely protected. And because she twisted an ankle, she's like, don't bring the kids, they make me run around too much, and so I'll twist my ankle again and hurt myself. So now at least she's totally safe. But that's the advice. Keep the people around you safe. All right, take good care of yourself. I look forward to talking to you again. If this home situation gets prolonged, I may do another one of these videos in a week or two. All right, take good care. Have a lovely, lovely day. Bye.